Good evening, everybody. And at the outset, I would like to thank Dr. Vijay Thirukumar as well as Batiklo Medical Association for inviting me to deliver this lecture today. So the topic today is management of a child with chronic liver disease. To start with, I'll introduce the basic facts I would be touching during this lecture. So let's first have an idea about the definition of chronic liver disease. What does it mean by chronic liver disease? And then the disease conditions which would cause chronic liver disease very briefly. And then we will remind about the clinical features we would see in a child with chronic liver disease. And basically, I would be touching mainly on the management in keeping with the topic of the lecture today. So bulk of this lecture would be about the management of a child with chronic liver disease. Firstly, let's look at the definition. So we all know the normal liver would look like it's very bright and reddish and it's very smooth. But in contrast to that, you can see a cirrhotic liver in the right side, which would give rise to the clinical picture of chronic liver disease. So if you look at the definition is ongoing inflammation in the liver for at least 6 months with the potential to progress to cirrhosis and end-stage liver disease. So if we carefully try to understand this definition, it says ongoing inflammation. So are we really clear what is meant by the inflammation in relation to chronic liver disease? Is it always inflammation? It's quite straightforward. If we take autoimmune liver disease, yes, there is inflammation. Or else if you take an infectious cause, again, there may be secondary inflammation, secondary to infection. What about metabolic disorders and other genetic disorders? Is it the same mechanism? Actually, yes. Finally, the cirrhosis would result as a result of inflammation. What would happen is there may be different mechanisms of liver injury like cholestasis, steatosis, or direct inflammation, direct toxic mediated injury. Whatever the initial mechanism, final pathway is inflammation, and then the liver cells or hepatocytes attempting to repair the hepatocytes, which would ultimately result in cirrhosis or fibrous tissue deposition. So basically, in simple words, what would happen is this inflammation would result in loss of hepatocytes and replacement of the hepatocytes with fibrous tissue. So we all need the liver cells or hepatocytes to do its function. Once it's replaced by the fibrous tissue, obviously there won't be function as it's expected. And what about the duration? The definition says 6 months. Do we all agree with this 6 months? What about a child with biliary atresia coming to your clinic or coming to your board at around 5 months of age, having all the features of chronic liver disease or liver failure, where the child's age is only 6 months or less than 6 months? Yeah, again, that is the drawback of this definition. You might not really see 6 months or child might die before 6 months. So it's always a clinical definition you would use rather than a technical definition. However, in theory, it is 6 months, but practically it might not be 6 months, even 4 months, 5 months, or maybe before that. Having that in our mind, we look at what are the disease conditions which could cause chronic liver disease in children. So this is to give you a brief idea about the wide spectrum of disorders or diseases which could cause chronic liver disease picture in a child. Purposefully, I have highlighted biliary atresia. I'm sure you will believe me if you come to a hepatology clinic or hepatology unit, 60 to 70% of the children with chronic liver disease are biliary atresias. They are quite young and failed Kasai most of the time because of the delayed presentation and biliary atresia. So it's very, very important we know in and out of biliary atresia because that's the commonest. Apart from that, there are the genetic disorders, metabolic disorders, and maybe storage disorders, malignancies, drug-induced liver injury, various causes, which would ultimately cause the clinical picture of chronic liver disease. Let's briefly remind ourselves what are the clinical features we would see in a child with chronic liver disease. Let's try to go methodically. if you see a child, in keeping with our basic examination techniques, we would go with the general examination. So what are the implications? Growth is very, very important. The reason is, as a result of their chronic liver disease, they can have impairment of the growth. They might have stunting, they might have wasting, and they might have delayed puberty. So it's very important that you assess their growth with the usual anthropometric parameters as well as some special parameters which I would mention later in relation to growth. And also pubertal assessment, it's very important. You might see a 16-year-old child with chronic liver disease where the Tanner stage is delayed. So that is also important in assessment. What about sensorium? Is there a clinical relevance for the sensorium? Yes. The child might be having a low grade of hepatic encephalopathy. So the sensorium is very important for a child on general examination. Looking for whether the child is febrile or document in temperature, it's very important. Having a diseased organ in the body, that itself can give rise to low grade fever. Or on top of that, you might get cholangitis, might get spontaneous bacterial peritonitis, or else they might get any other infections as well. The reason is they are immunosuppressed. When they are having chronic liver disease, it's kind of a immunodeficiency status. So it's very important you look at the fever. Nevertheless, they might not have fever in certain times. Again, the reason is due to lack of immunity. They might not develop an inflammatory response. So it's very important to keep in mind, fever might not always be there when there is sepsis. In certain times, they might be hypothermic as well. Jaundice will be pretty obvious. What about the examination of the conjunctiva? Pallor, due to multiple reasons. Maybe due to anemia of chronic disease, maybe due to GI bleeding, which may be obvious or which may be occult. There are multiple reasons which can give rise to pallor. What about the other entity, plethora? How can we relate plethora into chronic liver disease? We all know that chronic liver disease can cause hepatopulmonary syndrome as a complication. So it's very important to detect these physical signs in view of the complications of chronic liver disease. So if the child is plethoric, that should raise the suspicion of having polycythemia secondary to hepatopulmonary syndrome. You might see cave rings to the naked eye if the underlying diagnosis is Wilson disease. However, it may be difficult. Cyanosis. If you see this little girl, you can see the lips are cyanosed. Sometimes it might be missed. She looks otherwise well, but she has advanced hepatopulmonary syndrome. Though I have mentioned cyanosis as a physical sign, I would strongly recommend we would not wait till the child develops cyanosis. We should have our saturation monitoring as part of our outpatient assessment and part of the follow-up of a child with chronic liver disease. And we should not wait till them developing cyanosis. Still, there are cases where they come with cyanosis. Oral hygiene is very important. Why do I try to highlight oral hygiene here? One reason is, again, that's support of infection. That's support of infection. And the other reason is, if they are on the transplant waiting list, it's very important they are maintaining good oral hygiene. Apart from that, they can have bleeding tendencies, especially due to thrombocytopenia and thrombosthenia. So they can have frequent gum bleeding as well. So it's very important they maintain a good oral hygiene. And you might look at that during your examination. Can they have hirsutism? Sometimes you might have seen little babies who have got a lot of facial hair, which might go unnoticed as well. That is due to increased levels of androgens, which are impaired in view of metabolism in the liver. So the androgen excess can cause hirsutism, sometimes maybe subtle physical signs. Dysmorphism is actually not part of the chronic liver disease, but it might give you a hint, especially for Alagille syndrome. What are the other features in general examination? Scratch marks, very important. In small babies, they get the scratch marks over the earlobes and maybe over the body. Spider nevi in the superior vena cava distribution. They may have gynecomastia, clubbing, palm erythema. Again, very important to see. And you can see in this picture, this child is very irritable because of intense pruritus, and you can see very thickened skin. And here you can see the evidence of palm erythema. They may have leukonychia or white nails, flapping tremors if they are in hepatic encephalopathy, and they might have pitting In an older child, it may be in the legs, and in a younger child, it may be sacral edema. Especially in Alagille syndrome, you may see xanthomas. So those are the important features in general examination you should look at, or you should focus in a child who has got chronic liver disease. Let's briefly recap what are the things we would look at in abdominal examination. I would not go for other systemic examination, but briefly to look at abdominal examination. You will obviously see a distended abdomen. And it's very important to see whether the abdomen moves with respiration. Why is that? If there is an evidence of spontaneous bacterial peritonitis, the movements may be sluggish due to the pain. So it's very important to note that. And dilated veins due to portal hypertension. Hernia, umbilical hernia, inguinal hernia may be apparent because they get raised intra-abdominal pressure. Superficial tenderness is quite important, especially in view of spontaneous bacterial peritonitis. What are the things you would examine when you see the liver? You have to examine for the liver span. If it is chronic liver disease, unless it's a storage disease, you usually see a shrunken liver. And this shrinkage is usually in the right lobe. You might see reactive hypertrophy of the left lobe or the caudate lobe sometimes. And the consistency of the liver, it would be very firm or firm to hard, and usually non-tender in the context of chronic liver disease. And it's very important to look at the upper border of the liver unless you might miss a shrunken liver. Then you may move to look at the spleen. It's very important to look at the spleen size and the progressive enlargement of the spleen in view of portal hypertension. You might ballot the kidneys, especially if they have cystic disease associated. In case like Alagille syndrome, where renal cysts are known associations. So there is a clinical significance in looking at the kidneys. Obviously, you will look at free fluids, and genital examination is important. In a smaller child with raised intra-abdominal pressure, it may be the hernial orifices, hydrocele, and sometimes you may do a genital examination in view of canal staging. Before moving to management, I would like you to understand the terminologies related to chronic liver disease a bit briefly. In the context of chronic liver disease, we talk about compensated chronic liver disease, decompensated chronic liver disease. Sometimes we just tell acute and chronic liver failure and end-stage liver disease. What do these terms mean actually? I think it's very easy for me to tell you clinical scenarios and explain this very briefly. The first scenario would be you get a 8-year-old child coming to your clinic who had biliary atresia and who had a CASI. And when an 8-year-old child walks into your clinic, usually in good condition, who had a CASI, you know this had been a successful CASI. If this was not a successful CASI, this child would have either died or would have required a liver transplantation. So this is a successful CASI. And child looks quite well. Tummy doesn't look distended and reasonably well looking. So this is compensated chronic liver disease. However, if you do a biopsy, you will see cirrhosis. If you do evaluate the biochemistry, you might see some decline in synthetic functions. Still, the child remains compensated. So that is compensated chronic liver disease. we'll look at what is decompensated chronic liver disease, and that would actually help you to understand more about compensated chronic liver disease. If you do not have features of decompensation in the context of chronic liver disease, you can say that is compensated. So what are those features where I would say this child has decompensated chronic liver disease? I would like to highlight three main features actually. One would be having ascites. Number two, having encephalopathy. Number three, having acute upper GI bleeding. If you have ascites, if you have hepatic encephalopathy, and if you have acute upper GI bleeding, that would make your chronic liver disease a decompensated one at that point. In the absence of those three, you may call it compensated chronic liver disease in most of the time. And this decompensation, is it a sudden thing or is it a gradual thing? Then only we need to understand acute and chronic liver failure. When these features are quite acute, sometimes maybe the first presentation in undiagnosed chronic liver disease, that is acute on chronic liver failure. If it is quite acute, within few weeks. But when these things happen gradually, that is decompensated chronic liver disease. So it's very important that we understand these terms because these two entities have got different etiologies sometimes and different prognostic factors, which I'm not going into detail because it's beyond the scope of today's lecture. This is one of the literature I have extracted to highlight. In children, acute and chronic liver failure was recognized as a separate clinical entity in the recent past. So you can see this publication came in 2016 as a highlight of acute and chronic liver failure in children as a separate clinical entity. You may think we have been using this term on and off. So did this not exist? I think it has given us a better understanding to differentiate acute and chronic liver failure from decompensated chronic liver disease. Acute and chronic liver failure usually occurs in the context of Wilson disease, autoimmune liver disease, like specific etiologies. But decompensated chronic liver disease usually occurs with biliary atresia and other etiologies. So etiological wise and prognostic wise, it's different. Acute and chronic liver failure has got a high mortality and high requirement for liver transplantation. Decompensated chronic liver disease usually can be settled with medical management till you plan your transplant. They might not require urgent transplant. In contrast to that, ACLF or acute and chronic liver failure may require urgent liver transplant. So what about end-stage liver disease? Usually we talk about end-stage liver disease in the context of decompensated chronic liver disease. If you have a child with decompensated chronic liver disease, where a child would die within next few weeks in the absence of a liver transplant, which you can anticipate by seeing the child and seeing the biochemistry, you would call it end-stage liver disease. I'll give you a few hints. If you have a child with decompensated liver disease, and if the child has got significant hyponatremia, that would make it end-stage liver disease. If the child has medically refractory grade 2-3 encephalopathy, that would make end-stage liver disease. So those are main things which would make a chronic liver disease decompensated one towards end-stage liver disease. And if you have a child with end-stage liver disease, that is quite late for transplantation, but can do, but it has to happen within few weeks. This is to highlight how a compensated chronic liver disease child may exist. So if you see this child looks quite stable, not very ill, standing on by her own. You can see her nutrition is not really right. She's quite thin. She has slightly distended tummy, but she looks reasonably all right. During this stage, she underwent a liver transplant, and this is her explant, or this is her liver. So you can see how bad this liver is, though she is compensated. And it was a wise decision that the team decided to do a liver transplant before she ended up with a decompensation episode or end-stage liver disease, where the outcome was quite good when the transplant was performed in the compensated chronic liver disease state. And you might not imagine this liver was this bad when she's standing like this, but that is the case. So this is just to highlight the importance, though they are well, how bad their livers are inside and how rapidly we should escalate their management into a liver transplant to achieve good outcomes. So far I have given you the definition of chronic liver disease with some limitations, and I've reminded you the etiologies and diseases which may cause chronic liver disease in children. We looked at the clinical features and few terminologies which are linked with chronic liver disease. Now we are entering into the bulk of the lecture or the crust of the matter, which is management of a child with chronic liver disease. Firstly, I would like to draw your attention to the role of investigations when we manage a child with chronic liver disease or maybe during the follow-up. So these are the investigations we normally perform when a child is admitted or when a child is on follow-up at different intervals. So let's see what are the important implications when we do these investigations. If you perform a full blood count in a child who has got chronic liver disease, what's the clinical significance? So in the full blood count, it's very important to look at the white cells in case of a subclinical infection, because they might not develop fever all the time. It may be just not being right as complained by the mother. So it's very important to look at the white cells and neutrophils. And hemoglobin. There are multiple reasons that hemoglobin may be low or hemoglobin may be high, especially in hepatopulmonary syndrome. Platelet count, again, it's very important. Looking at thrombocytopenia, and we should be aware there is thrombocythemia or platelet malfunction as well, in addition to thrombocytopenia, which we can't assess through full blood count. And we would be definitely looking at the red cell indices as well. Liver profile. I'm sure this audience is very familiar when I mean liver profile. You would do liver enzymes, AST, ALT, gamma-GT, alkaline phosphatase, albumin, total protein, globulin, and bilirubin with a split bilirubin or direct bilirubin. So all these are important to understand. How about the synthetic functions, especially creatine and albumin in vivo of synthetic functions? How about the excretory function, bilirubin and ammonia in vivo of excretory function? And what about the enzymes? What's happening with the enzymes? I would like to mention a word about the enzymes actually. When it comes to late stage chronic liver disease, the enzymes are not really useful. I'll give you an example. You might have a 9-year-old child with biliary atresia who's compensating at present. However, synthetic functions are gradually declining and we think that the child requires liver transplantation. If you look at the AST-ALT, that may be normal. Why is that? Does that indicate the liver functions are normal? No, that is not. He doesn't have much hepatocytes to produce AST-ALT. And also, AST-ALT or the transaminases are not good indicators of synthetic function. So you would never underestimate how bad a liver is by looking at transaminases. We should never do that mistake. We should never look at the transaminases in a child with chronic liver disease and should not get reassured that this child is doing well. We should look at the trends of albumin and prothrombin time. In vivo of clotting, what we normally do is prothrombin time, but it's important to do APTT in vivo of vitamin K deficiency. And it's good to have a ROTEM if you can have. Having said that, we have to be very careful when we use ROTEM as well, because in the country at a given time, there are limited resources, limited reagents, and ROTEM is very important when it comes to liver transplant care. So we have to be very cautious when we use ROTEM as well. We should be requesting it for everyday practice, but it's quite useful provided we have the resources. Alpha-fetoprotein. What's the importance of alpha-fetoprotein in the context of chronic liver disease? I'm sure you would agree with me, they have a likelihood of getting malignancies or secondary malignant nodules. So you combine their follow-up with ultrasound scan every 6 monthly with alpha-fetoprotein, where the trends would be important in view of detecting early malignant nodules. Any child with chronic liver disease can have malignancies as a secondary occurrence. Especially the risk is high in PFIC2 and tyrosinemia. Vitamin levels, again important. We normally put children with chronic liver disease on fat-soluble vitamins, water-soluble vitamins, but the rational management would be if the resources are available to do the vitamin levels and then titrate. Vitamin D levels can be done in the country, in the state sector, in teaching hospitals, and vitamin K level can be assessed in view of prothrombin time, but not every time because it has a liver synthetic component as well. Vitamin E level is not available as far as I know in the government sector, but it is something which can be done. And again, vitamin A levels as well. So basically, as much as possible, especially vitamin D levels, we can rationalize when we use them. The reason I would tell you, because when we use medications in these children, we have to minimize the number of medications as well. We might give 10 medications for them that might impair their oral intake, appetite, because when they have a lot of pills to take, that might have disadvantages in view of quality of life, in view of appetite, nutrition. So it's very important we look at those aspects and we rationalize the drugs we give as well as much as possible. Ultrasound scan and Doppler and CT, how are they going to be used? Usually we do perform ultrasound scan every 6 monthly unless there is a reason to do that earlier. There are a lot of things that we can gather from ultrasound scan. The radiologist would help us, giving some idea about the liver echogenicity, what's happening, and portal venous Doppler, what's happening with the portal hypertension, splenic size, that is also very important. When you monitor a child for portal hypertension, it's very important you look at the trends of the spleen size. That is helpful for you to plan your endoscopies. Compared to 6 months back, and if the spleen size is going up, you know that you might have to escalate your endoscopy a little bit earlier. And the radiologist might tell you that there are intra-abdominal varices, and the radiologist might tell you about focal lesions, which you might biopsy. So all these things are quite useful information and free fluids and usual things we check. CT scan is not routinely done in everybody. It is done if you are going to a transplant assessment or if you have a focal lesion which needs further assessment in selected situations. Upper GI endoscopy crucial. Every child with chronic liver disease will have an element of portal hypertension. But in certain etiologies like biliary atresia, they have a higher chance of getting severe portal hypertension. So you will need upper GI endoscopy diagnostically as well as therapeutically. What about monitoring the degree of fibrosis? We know the liver biopsy is the gold standard to say cirrhosis and the degree of fibrosis. However, the limitation is it's quite invasive. We can't be doing it every 6 monthly or yearly. So now we have novel modalities like FibroScan or transient elastography. When you do it serially, it helps you to identify the progression of the cirrhosis as a non-invasive marker, which is available in the country. And depending on the complications you suspect in the child, you may arrange an echocardiogram or bubble echocardiogram. And ammonia levels are not routinely done, but if it is possible, yes, that would indicate the excretory function of the liver. So those are the investigations in view of biochemical tests, imaging, histology, all these things which might be useful for you to get some idea about the particular child you are looking after. I am unable to give a frequency where you should be doing, how frequently you should be doing endoscopy, how frequently you should be doing other blood investigations, because it has to be an individualized approach depending on your child's clinical status. You may discuss with the hepatology unit and then have a plan in place for that particular child in view of the child's clinical status. But these are the things which are useful, and that is how they are going to be useful. Now let's look at different aspects of the management of a child with chronic liver disease. Firstly, I thought I would discuss a bit about portal hypertension and GI bleeding, because this is a common complication we see in the context of chronic liver disease. Just to recap about our theory, we know when we talk about portal hypertension, there are three main causes or mechanisms of portal hypertension: pre-hepatic, hepatic, post-hepatic. It's quite simple. And when you have liver disease, it is hepatic. Due to multiple reasons, the problem is with the liver. Normally, you get the blood flow from the spleen and towards the gut, from the gut towards the liver. However, if the liver becomes cirrhotic and if the liver becomes very stiff, the flow might not happen and there may be reversal of the flow, which would give rise to portal hypertension. So that is quite straightforward. So we know the cirrhosis or the chronic liver disease would cause portal hypertension. Is that the only reason you would see portal hypertension in a child with chronic liver disease? Could pre-hepatic or post-hepatic may contribute? Yes, it could, especially pre-hepatic. The reason is a child with chronic liver disease may have or may develop secondary portal vein thrombosis. As we know, there is sluggish flow and there is dysregulation of the clotting and anti-clotting mechanisms, and obviously there may be endothelial injury, which would increase the risk of thrombosis. And when the flow is sluggish, essentially it would give rise to portal vein thrombosis, which is not the portal vein thrombosis which we see associated with pre-hepatic since young childhood. This happens in a child with chronic liver disease as a secondary thing. May at the age of 9 months, maybe at the age of 5 years, maybe at the age of 10 years. So it's very important we look at these things in the follow-up ultrasound scans and we become very conscious about these factors as well, in addition to cirrhosis causing portal hypertension. And when you talk about GI bleeding, it's not actually portal hypertension. There are other reasons like coagulopathy and the platelet dysfunction. And I would tell you, it's not actually the vitamin K deficiency or the prolonged prothrombin time which would cause bleeding. It's the platelets. It's the thrombocytopenia and thrombocythemia. That has a major role to play compared to prothrombin time. You may have a child with INR of 6 who might not bleed, but still you might have a child with platelet dysfunction and thrombocytopenia who would bleed from the portal hypertensive gastropathic mucosa. So it's very important you identify these things, because when a child comes with bleeding, we should not be in a rush to correct these clotting factors, because that might cause adverse effects, such as causing secondary the numbers. We should rationally think what is the risk of bleeding and it is, and what are the factors which are actually contributing to bleeding. That is where a ROTEM would help in rational transfusion of blood products. A little bit about diagnosis of portal hypertension. Actually, in the 21st century, we talk about hepatic venous wedge pressure and the differences between hepatic venous wedge pressure when you diagnose portal hypertension. Though it's a nice term, it's quite invasive, so we can't really do that in each and every child, but that's the gold standard. And that is very useful in a special category of children, especially the children with the intestinal failure associated liver disease, or IFALD, where in that particular group, you don't really get splenomegaly sometimes. And splenic size is not correlated with degree of portal hypertension. So in that group, this portal venous wedge pressure is quite useful and it's being used in other countries. Ultrasound scan, Doppler will help, and varices on upper GI endoscopy will help you to diagnose, and varices may be visualized on imaging like ultrasound scan and CT. So what about the management of portal hypertension? We'll come to the management of an acute upper GI bleed. Before that, just to remind the medications we use. Actually, very limited data. If you use the data about the medications, this was published in 2021 in Expert Opinion on Pharmacotherapy about the pharmacological management of portal hypertension in children. The opinion was, actually, the large multi-center prospective studies will be needed to begin to establish an infrastructure on which a pediatric specific research agenda can be built. And they have clearly told that there is no convincing data because of lack of trials. So what we basically use is we use adult data, which is not really right, I think. And the medications wise, we have few options, losartan and propranolol. I would like to use losartan in younger children. The reason is if you use a beta blocker, their heart rate response is abolished. So that might have some negative consequences when they have a bleed with their hemodynamic mechanisms. So I would prefer losartan in infancy, especially less than 2 years, I would say. Propranolol can be used in a non-asthmatic. Some people do use carvedilol, but the data is mainly for adults when they have a lot of cardiac comorbidities. I feel propranolol is better than carvedilol, but yes, we don't have data. Other medications-wise, omeprazole and sucralfate are useful, especially to avoid or minimize the bleeding from the portal hypertensive gastropathic mucosa. So these are the very limited medications we have, and we really don't know whether they are beneficial. What about endoscopic management? It's very, very effective. That is which is effective. Band-in or sclerotherapy. Band-in may not be possible in a younger child, where we might have to do sclerotherapy, but if we could do band-in a child possibly more than 2 years, where you can pass the band through the pharynx, it's very, very useful, but you have to do it quite frequently and then abolish the varices. Sometimes what we not do is we don't do it frequently and abolish the varices. We just do one endoscopy and then we do another one in 1 year time. That is not right. If you see varices, you might have to do it frequently, abolish varices, and then put the child on the surveillance program. Sometimes you can use Sengstaken tube, which is shown in the picture. When you have uncontrolled upper GI bleeding, you may use TIPS procedure as an emergency measure to bridge for liver transplantation. So basically, if you have done your whole medical management and if you have failed with endoscopy, then you can do TIPS as a bridge for liver transplantation. However, medically or endoscopically uncontrollable portal hypertension or bleeding should be escalated for liver transplantation. This is to give you an idea about the scores we have. This is APRI score, which you can be downloaded as an app from the internet. And this is actually useful, especially in children with biliary atresia, to predict the risk of portal hypertension. You can calculate APRI score when they come to the clinic and predict the risk of bleeding as well as progression of the varices. What about management of an acute bleed? We all know when a child comes with acute bleed, resuscitation is the first step. And then the medical management. So let's look at what do I mean by medical management. Obviously, if a child comes with acute upper GI bleeding, keeping the child nil by mouth is crucial till the bleeding settles. And putting an NG tube, open drainage is helpful for you to understand how much is bleeding inside. As well as drainage is quite important. If you have the blood inside, it might increase the risk of hepatic encephalopathy. So it's very good to drain them outside. Vasopressin, octreotide, yes, they are useful. They can be used and escalated in view of acute GI bleed. You can start octreotide from 1 milligrams per kg per hour, 1 mics per kg per hour, and then escalate to 5 mics per kg per hour. However, one point to highlight about octreotide, we all know that can be used. If you have a smaller child, infant, especially where the portal venous size is quite smaller, be a little bit careful not to start octreotide for everybody who has got a mild bleed. The reason is they might get increased risk of thrombosis due to the constriction of the vessels, which might make them untransplantable. So we have to take a balanced decision when we start them on octreotide as well, especially in small children when they have small caliber portal veins. Especially as we have the transplantation in the country at present, we have to be conscious about those things as well. Antibiotics important when you have upper GI bleed because they can get decompensated with the bleed. So it's important to cover with antibiotics. And target hemoglobin is usually 7 to 9. We do not try to transfuse them over 9, and we accommodate a hemoglobin of 7 unless they have heart failure. The reason is if you transfuse them more and if you fill the compartment more, they will bleed more. So you maintain a low hemoglobin. And it's important to correct vitamin K deficiency, platelets, and maybe ROTEM guided correction of the factors, IV omeprazole, oral sucralfate. Those are important. And again, it's better to avoid tranexamic acid, again, due to the risk of thrombosis. A word about bleed-in letter. We do practice something called bleed-in letter. If we have a child with portal hypertension, we give them written instructions pasted on their clinic book. If they get admitted to a local hospital where you have that letter in the clinic book, which will give you written instructions in case of an emergency, how to manage an acute GI bleed, including the doses and instructions. So we do practice that for children we look after in Ragama. Most of them will have the bleeding letter pasted on their clinic book with written instructions where you can just look at it and put a management plan, including our contact numbers. If you fail in your medical management, as I mentioned earlier, you have to go ahead with endoscopic management as an urgent thing. Otherwise, we would do it as an interval endoscopy. But if you have bleeding which is uncontrollable, then you will do acute endoscopy. TIPS and liver transplantation are the final resorts. TIPS is not the final resort, it's the bridge for liver transplantation. Liver transplantation is the final resort. So that's about portal hypertension briefly. What about ascites? Ascites in a child with chronic liver disease is multifactorial. We know it may be due to low albumin as well as it's due to portal hypertension. So you have to correct albumin, especially if they have albumin of less than 2.5. It's good to pick it up for 3.5 if they have significant ascites. What we use is 20% human albumin. There is no use of 5%. What we have to use is 20%. The regimen is 5 milliliters per kilogram over 4 hours, which we usually couple with midway furosemide to get the maximum benefit. Diuretics are useful together with albumin as well as oral diuretics. I would prefer spironolactone over furosemide. The reason is these children would invariably have hyponatremia, and they are more liable to get complications of hyponatremia due to the fluid retention they get as a result of chronic liver disease. If you give furosemide, again, that would be aggravated. You can achieve a good balance with spironolactone compared to furosemide. So the first preferred diuretic would be spironolactone, a dose between 1 milligrams per kg per day to 5 milligrams per kg per day, which is quite safe. Low salt diet in a child who's on a diet more than 6 months. Volume restriction is sometimes useful, 70 to 80%, provided your hemodynamics are allowing that to be done. And if there is spontaneous bacterial peritonitis, again, you have to treat that. Though you give albumin, though you give diuretics, if there is an infection increase in the permeability of the peritoneal membrane, then again you will have ascites. So you have to treat that. What about therapeutic paracentesis? Do you do acidic drainage? It's not actually encouraged in children. The reason is there is no point. They will again get it filled up. What you have to do is increase the oncotic pressure with albumin and use some diuretics for gradual diuresis. Sudden decompensation or sudden decompression of the acidic fluid from the tummy is actually harmful. And it will increase the risk of infections as well. Very limited setup, maybe you have compromise of your respiration. In those scenarios, you might do, but otherwise it's not encouraged. And when you have refractory ascites, you give your albumin, you pick your albumin up, you're on maximum diuretics. Still, ascites is not really controlled. Think about secondary portal vein thrombosis as well. This is to give you some idea about how to interpret acidic fluid tap if you do that in vivo of spontaneous bacterial peritonitis. You will look at the white cells and you will look at the culture. Moving into hepatopulmonary syndrome, briefly, if you have liver disease, you can get abnormal vascular dilatations in the lungs and resulting in arterial hypoxemia, that is in brief hepatopulmonary syndrome. And it's quite common with biliary atresia. Child may be otherwise well, but might have advanced hepatopulmonary syndrome. So it's very, very crucial that you monitor their saturations, though they look well, monitor their saturations in upright position for 5 minutes. That is due to platypnea. What you get in hepatopulmonary syndrome is platypnea, in contrast to what you get in heart failure, which is orthopnea. So for you to detect hepatopulmonary syndrome, what you should be doing is asking the child to stand up or sit up in upright position and then monitor the saturation after allowing that position to be for 5 minutes. If the saturation is low, that is significant, or else you might see the difference between the supine and upright position. If it is more than 3% difference or decline, that is significant. Then you will go ahead with the arterial blood gas measurement and a bubble echo. Hepatopulmonary syndrome is an indication for liver transplantation. It's not a contraindication, it's an indication for liver transplantation. However, if it is very advanced, that might put you very complicated post-operative period, so we might decide not to do transplant. However, on theory, it is not a contraindication. You have to think about liver transplantation if you see a child with hepatopulmonary syndrome, which can be cured with liver transplantation. Nutrition. It's very important when we talk about chronic liver disease. I would say nutrition is a medication for chronic liver disease. If you see this child, you can see the child's tummy is distended, possibly with organomegaly as well as ascites. But if you look at the limbs, you can see wasting, loss of muscle mass, loss of subcutaneous fat. So this picture would tell you the usual growth parameters we would do might not indicate the severity of the problem. We might have to do different assessments in this child. And if this child undergoes a liver transplantation, the prognosis may be quite bad actually, quite not really right. The reason is child cannot undergo that stress of liver transplantation with this degree of nutrition. So it's very important that you correct and or optimize the nutritional status, considering it as a medication for chronic liver disease. So what are the reasons where the nutrition is affected in a child with chronic liver disease? Their intake is low, and they are on medications which might induce loss of appetite. They have high demand and high expenditure. There may be unnecessary restrictions due to MITs. Protein restriction, which is not really necessary in a stable child who is not encephalopathic. One might go for MCT feeds unnecessarily when the bilirubin level is not high, which are not really palatable in view of MCT feeds. And one might restrict fluid feeds thinking about copper restriction in a child with Wilson disease who is otherwise very well controlled. So those myths might give rise to poor nutritional status. And fat malabsorption due to cholestasis might give rise to deficiencies of vitamins. And there are inherent gut problems, especially in certain disorders like PFIC. Portal hypertension might cause enteropathy, which will reduce absorption. Frequent hospital admissions might not allow them to get good quality food. Loss of protein through blood and diarrhea, and sometimes feed intolerance because they have big tummy occupied by fluid and liver and spleen sometimes, and they don't have much space to occupy a feed. So all these factors would contribute for poor nutritional status. How do you assess? Compared to usual anthropometric parameters, mid-upper arm circumference is useful, tricep skin fold thickness, and hand grip measurement. There are no validated cutoffs, unfortunately, yet. However, the trends can be used. Some might do psoas muscle circumference on CT scans, but again, that cannot be done very frequently or repeatedly. Vitamin levels are important. DEXA scan may be helpful if you are thinking about hepatic osteodystrophy. In view of optimization, they need extra calories because they have extra expenditure and extra need. And these extra calories will help the liver to regenerate. That's why I always say consider nutrition as a medication to the liver. It will support the liver. And we should consider calories as well as proteins, and we should not unnecessarily restrict proteins. Diet and special diseases, I would not recommend MCT feeds unless the bilirubin is above 400 or 450, where the MCT feeds are not really palatable. So child might not take any feed. If the bilirubin is quite less, you can use normal feeds. We don't need to use MCT feeds. Special formula in case of galactosemia or metabolic disorders. Copper restriction is not really necessary if you are under control with chelators. And it's not going to give you much benefit compared to what you see with the quality of life impairment and their nutrition. So I'm not very much bothered about copper restriction in the diet. Low salt diet is very important in view of ascites and portal hypertension. Moving into pruritus, again very important. It's very important to detect and manage pruritus. The reason for the pruritus is mainly bile salts rather than bilirubin, which we normally don't check. So we might have a child whose bilirubin is normal but still have pruritus. So we should not hesitate to manage pruritus. General management is important. Skin care, keeping the skin moist, avoiding heat, and keeping the skin clean. Medical management, ursodeoxycholic acid, cholestyramine, naltrexone, and so on. Surgical management, certain disorders like PFIC, you can think about biliary diversion. It could be internal or external. Ultimate cure is liver transplantation. If a child's synthetic functions are preserved, still the child has got medically refractory pruritus, that would be an indication for liver transplantation. What about the risk of infections? They are more liable to get cholangitis and spontaneous bacterial peritonitis, which we have to keep in mind. And they might not get the textbook appearance of the fever with chills, worsening of jaundice or pale streaks. It may be quite subtle, still important to be treated. The reason is with each and every episode of cholangitis, the child's native liver gets damaged, and it will make the liver transplantation need quite early. So it's very important we give prophylaxis for them for cholangitis, and when they have features, even they are subtle, we treat them adequately with IV antibiotics for 10 to 14 days. We should not discharge them early. We should complete minimum 10 days. They are more liable to get chest infections. I've seen children dying with chest infections compared to other children. They are more vulnerable to die with chest infections. And other infections are also could happen, so we have to have an open mind. A word about immunization. It's important to complete their routine vaccination. No contraindication for vaccination, and we might do accelerated schedules if we are going ahead with liver transplant. Extra vaccines are important. I would consider this group of children as immunodeficient children. So I think it's very important we should consider pneumococcal, varicella, and hepatitis B boosters if the antibodies are low in children with chronic liver disease. They might not develop the same degree of immune response to the vaccination, again, which we have to remember. And one last important point in view of immunization, we have to be careful to look at their coagulopathy and platelets when we administer, especially intramuscular vaccines. They might get hematoma, which might get infected. So you might actively look at their coagulopathy before administering intramuscular vaccination. There are other complications which I'm not going into detail: hepatic encephalopathy, hepatorenal syndrome, and they can have cardiomyopathy due to cirrhotic cardiomyopathy, and portopulmonary hypertension, quite rare in children. Hepatopulmonary syndrome common, portopulmonary hypertension rare. These are the medications a child with chronic liver disease may be on. They would be on ERSO, they would be on fat-soluble vitamins, sometimes water-soluble vitamins, depending on the nutritional status, diuretics, prophylaxis for cholangitis, very important in biliary atresia and PFIC. Primary or secondary prophylaxis for portal hypertension, though we don't have evidence, we do put them on. Rifaximin, laxatives, and antipruritic medications. Counseling and psychological support, very important, because this is a chronic disease. And we know most of these diseases would end up getting a liver transplant, which is kind of a big commitment. So it's very important to put the family in the picture, what they are going to have in the future, what would the disease course be, and follow up, giving them helplines, as well as helping them with the financial stability. And in view of a liver transplant, we should think about donor preparation early. So this is just to highlight, if you look at these courses which I gave you at the beginning, what are the disorders where specific management is available in view of chronic liver disease? All what I have talked is general management for any disease with chronic liver disease. But if you look at the specific management, only few diseases are there, we can really put a specific therapy in place. So we have to remember, most of the time, the ultimate goal will be liver transplantation. So we should think and prepare the children and the families for that. But whenever we have a diagnosis where we can treat with specific management, again, we should take that opportunity and do it. Ultimately, a word about liver transplantation, as I cannot finish this presentation of chronic liver disease without mentioning about liver transplantation, because most of the diseases, it is the ultimate cure. And now we do have liver transplantation in Sri Lanka, and we have a program in Ragam, and the results are promising. So we should actively consider transplantation as an option for children with chronic liver disease. So this is to remind you the indications. If you have a child with chronic liver disease, these are the indications in that particular child. You may not need to have all these things in one child. You might have one or the other, but which would indicate a liver transplantation. This is to remind you the contraindications. There are several scores which are useful when you have a child with chronic liver disease, especially for Wilson disease, modified King's-Wilson index, which would give you some idea whether the child would require liver transplant. The other scores like MELD, PELD, child scores are not really validated in younger children. They have some limitations, so we have to be very careful when we use them. The main or the valuable thing would be you look at their trends of the synthetic functions and the list of indications which I have given earlier, rather than just being limited by the scores. What would be the follow-up of a child with chronic liver disease? It has to be individualized approach. I would have liked if I would have given a clear plan, this frequently, these investigations, this is the protocol, but unfortunately it is not possible because the children are different from one to the other. So we have to have individualized approach and shared care, especially with the liver transplant center in view of transplantation. If you are thinking about it, close contact and helplines with the family, and you may monitor them clinically, biochemically, imaging-wise, and endoscopically. So I've reached to the end of the presentation, and I would like to highlight a few take-home messages. More than any other time in this particular time in our country, I think we have to concentrate a lot about management of chronic liver disease. The reason is now we do have liver transplantation. Few years back, we did not have that option in the country where we had to allow the children to die other than a very minority going to overseas and getting it done. So we managed them quite conservatively when we knew that there is nothing else would help other than liver transplantation. However, now the situation is different. The things have changed. Now we do have liver transplantation in the country. So it's very important we look after these children carefully and optimally and escalate them for liver transplantation. and maybe delay the time of liver transplantation by optimally managing them. An individualized management plan and shared care is important in view of better outcomes. I would like to end my presentation with this nice smile given by the child, 6-year-old child who underwent liver transplantation by the team in Ragama 2 weeks back. And I should remind about the hard work done by the Colombo North Center for Liver Disease and the staff in Ragama, in all the pediatric, surgical and other units. And this smile was given to us after 2 weeks following transplantation, and that was for acute liver failure, but this would be the same case if they undergo for other indications as well. So the results are promising, and we have to consider liver transplantation as an option in the current era.